Hey guys, welcome back to my channel. Today's topic is AOGD January 2025 Bulletin. Okay, first in this, it basically the concept is sepsis. So, sepsis management and what are the different protocols and all. So, first thing, what are the different approaches for maternal sepsis, indicators, and management? Okay, so sepsis is the third most common reason for maternal fatalities, and mm, mainly, the mortality and morbidity is because there is delay in identification and there is less non-standardized management. Okay. So, what is definition? Sepsis is a life-threatening organ dysfunction, which is because of host response to the infection is dysregulated. Okay. Septic shock means if we require vasopressors to maintain the blood pressure of more than 65 mmHg, that is mean blood pressure of 65 mmHg, and or present serum lactate of more than 2 in the absence of hypovolemia. Fluids we are giving totally. Even then the serum lactate is more than 2, then that indicates septic shock. Okay, so WHO gave a definition for maternal sepsis. It means it's a life-threatening condition where there is organ dysfunction which is caused by infection of pregnancy, delivery, puerperium, or after abortion. So during pregnancy, after delivery, puerperium, and if there is any abortions. Okay. So our RCOG have a GTG number 64 which shows the signs and symptoms. Let's fix to red flag symptoms. Okay, here the mental status is GCS less than 15, respiratory rate of more than 25, oxygen saturation of less than 94, heart rate of more than 130, blood pressure systolic of less than 90, urine output if she is not passed the urine for more than 12 hours, or if the urine is less than 0.5 ml per kg per hour. Okay, these are red flag signs. So you should write this mental status, then respiratory rate, then oxygen, then heart rate, then blood pressure, then urine output. Okay, these things are the red flag signs. If it is there, then there is sepsis in pregnancy. Risk factors. First, we'll learn about obstetric risk factors. Obstetric risk factors is something if there is any invasive thing. Invasive thing means if there is something the membrane has been ruptured, like prom. If we do cesarean, that is invasive. Vaginal trauma, that is we are entering into the vagina. Okay. RPOC, and inside some tissues there. Okay. Amniocentesis are also invasive. Cervical circulation, that also we are doing dealing with invasive surgery. Multiple gestation is the only thing which is non-invasive. So obstetric indications are risk for maternal sepsis. These other other conditions like obesity, diabetes. Okay, if there is anemia, age. Okay, immunity is decreased, ethnicity, any other systematic disorders, infection, gas infection, intravenous drug users. Okay, these are different risk factors. So what is the pathophysiology of sepsis? So generally, what happens is because of infection, because of multiple factors, it results in intravascular hypovolemia, tissue hypoxia, ischemia, and mitochondrial malfunction. Finally, there is organ dysfunction, finally, death. Okay, so actually, what happens in pregnancy is there is increase in heart rate, there is decrease in blood cells, blood pressure, and increase in white blood cells. So we can't differentiate what is sepsis, what is pregnancy, pathological changes. Okay, so um, so it can mask the signs and symptoms of infection. Okay, so you should find the source of infection before ruling out that she's suffering from maternal sepsis. Like it can be abortion, chorioamnitis infection, endometritis, RPOC, wound infection, mastitis. These are conditions where she can run in maternal sepsis. Non-obstetric causes are already told, and almost 30% of cases we can't find what is the source. So, what are the early warning signs we can find out? Okay, there are different things like vital signs of infection warning scores are present. Initially, they used to use a sequential organ failure assessment, that is SOFA score. If the score is more than 2, then it represents organ dysfunction. Now it came Q SOFA, which is quick sequential organ failure assessment. Okay, like we'll see some points like Glasgow comma scale, blood pressure, and respiratory rate. If GCS is less than 15, if GCS is less than 15, blood pressure is less than 100, and respiratory rate is more than 22, and any of the on these three, if any two are present, then that means Q SOFA is positive. Okay, yeah, shock index is one more thing. It is nothing but heart rate by systolic blood pressure. If heart rate by systolic blood pressure is more than 0.9, it is indicator of hemorrhagic and septic shock. Cues of criteria are the most affected by pregnancy, creatinine, and MAP cutoffs. So I want to say that because pregnancy have different scores, we can't use SOFA score exactly in pregnancy. So there are scores like SOS, MEOS, and OM SOFA. Okay, so questions can be getting like MEOS. So MEOS is something important scoring. MEOS is modified early obstetric, is for obstetric warning system. It is specific for pregnancy. Okay. So obviously when a person comes with fever or shock, what you'll do? You'll take the vitals. What are the vitals? Temperature, blood pressure, heart rate, respiratory rate. Even doing these things, we'll see whether she is conscious or not. Hello, what's your name? You'll ask in that. The state of consciousness. Then nowadays there is SPO2 probes, you remember? SPO2 probe will give that. So whatever we'll see the consciousness, we'll see the temperature and vitals, and SPO2 probe is MEO score. Ohm SOFA is obstetrically modified SOFA score. Here we'll add CNS system examination, creatinine. SOS is sepsis and obstetric score. Here also temperature, blood pressure, heart rate, respiratory rate. SpO2, white blood cells count. Blood test also will send for white blood cells and immature neutrophils, and we also send lactic acid. Okay. Mostly people will confuse that MEOS scoring having lactic acid. No. MEOS scoring is basically MEOS scoring is very important, and this is the scoring we generally do without knowing when the patient comes. Okay. Now we learn about this sepsis two-step system. Okay. This was adapted by Society of Maternal and Fetal Medicine Consultant series. They adapted this. Okay, we'll see. See, if a patient came and you're suspecting infection, you will do the vital signs and WBC screening. Step one is we'll do temperature, heart rate, respiratory, and WBC, and WBC only. So temperature and all these things we'll see. If in this four they are two positive, then we'll suspect some infection. We'll start the antibiotics. We'll give IV fluids. Okay, we'll start these things. And I told that in meantime we'll do the blood pressure also. If mean arterial pressure is less than 65 mmHg, then in within 15 minutes we'll give IV fluids like 30 ml per kg body weight, because it defines septic shock. Okay, even after giving this 30 ml per kg body weight, if the mean arterial pressure is less than 65, it indicates septic shock. Then, how to confirm sepsis evaluation? This is you're doing the screening. This step is screening. How to confirm with if the septic shock is respiratory mechanical ventilation needed is thing. They needed mechanical ventilation. There is coagulation defect like less than 1 lakh platelets. PTNR is increasing. Bilirubin is more than 2. Cardiovascular, if the MAP is less than 65. Creatinine is more than 1.2. Okay. Urine output is less than 0.5. Mental status is agitated and confused. Lactic acid is more than 2. So if these lab tests are showing some features, if any one of these features is present, then it is septic. This is sepsis confirmation. All are negative, then we'll close monitor. If elevated lactate during labor, then we'll again send the lactate levels. Okay. If more than one criteria is present, then we'll start the antibiotics and we'll give IV fluids. Okay. We'll escalate the treatment. If septic shock is present, then we'll admit her to ICU. Okay. That's it. So treatment is first thing, there is shock. So we'll make every measure to stop the progression, and we'll give the IV cannula 16 to 18 gauge cannula. Then a sepsis 1 hour bundle will do. Okay. These recommendations were adapted by the Society of Maternal and Fetal Medicine in 2023. This includes we measure the lactate levels. If less than 2, uh, death are correlated with lactate levels. Like for example, if more than 4, then 40% death is there. It's a signs of hypoperfusion. Lactate levels is signs of hypoperfusion. We'll open the blood for culture, but we should start the antibiotic, not to wait for the report. Then you'll start the broad spectrum antibiotics. Then you'll start the IV fluids like 30 ml per kg body weight. Organ perfusion should be rapidly. Okay. Initial rehydration should be given. What are the different antibiotics to be given? Like if you're suspecting any pneumonia, respiratory distress, then you can start ceftriaxone. Hospital like acquired pneumonia, ceftriaxone. To cover pseudomonas, we'll start aminoglycosides like amikacin. Uh, but yeah, any case, in Korea amenities also we will give ampicillin plus gentamicin. UTIs we can give gentamicin. Abdominal infections, you remember piperacillin so we'll be giving for abdominal infection. Even skin also will start piperacillin. Okay, so mean arterial pressure indicates a tissue perfusion. It should be more than 65. Okay, septic shock requiring vasopressors if the mean arterial pressure is not maintained. Only the first vasopressor of choice is norepinephrine. Highly saturated patients we can use dopamine. Okay, dopamine is a inotropic agent of choice. Some people says that we should give corticosteroids who are requiring vasopressor to maintain BP. 1 hour after 1 hour of these complementary measures, we start focusing where is the infection. If there is an abscess or any wound like a cesarean wound infection, you start doing the debridement of that wound. Okay, definitive control of continuous source of microbial contamination should be stopped. See, most important mistake we'll do is we'll admit the patient, we'll do all resistive measures, we'll keep in ICU, and we'll leave the patient. Okay, no one is scared to check the abdominal wound, cesarean wound, or episiotomy wound, breast. That way, there's no one to check. If they checking that, they can find any breast abscess. So if they find that, better to do DNA like drainage and incision and drainage. IND should be done to remove the infection focus. Okay, stress ulcers prophylaxis is given. Um, then, so this is the thing. You should identify the sepsis 1 hour bundle, definitive management, additional therapy should be given. Okay. So, golden hour, we should implement all the measures. So, this is about sepsis. Very important point I felt in this bulletin is these red flag signs. Okay. Red flag signs that is mental status of GCS more than 15, respiratory of more than 25, oxygen saturation less than 94, heart rate more than 130, systolic blood pressure of less than 90, urine is not passed for more than 12 hours. Okay, then you have Mayo score where all the vitals are being checked: heart rate, temperature, blood pressure, respiratory rate, state of consciousness, and SpO2 probe. Okay, antibiotics should be given without waiting for culture. Now we learn about second topic. This what are the blood products? How much we need to give? Okay, so obstetric hemorrhage is a leading cause of pregnancy-related death. Okay, so see, 500 to 1000 it is minor. If more than 1000 is major hemorrhage, and hemodynamically stable antenatal period. Uh, see, even in pregnancy, there is increase of plasma volume by 50%, red cell volume by 30%. So, uh, so this increase helpful if there is any uh, hemorrhage also, this compensate. Okay, even then, if it is more than that, then it can result in adverse effects. Okay, so FIGO 2022 says that we should use shock index in diagnosing the management of PPH. If the values is a shock index, what I said, heart rate by, come on, heart rate by systolic blood pressure, very good. So heart rate by systolic blood pressure is 0.9, then it is shock index is more, the adverse effect can cause. So this should be, so if more than 9, 0.9, it indicates it is hemodynamic instability. Okay. Then how to recognize and prevention. This is ACOG 2020 guidelines. So first we'll recognize it. Okay, like we'll see hematocrit, hemoglobin, long oxytocin. So these are different conditions where you can expect that there will be hemorrhage. Okay, like giving magnesium sulfate, long oxytocin use. If platelet, see most of our oxytocin I felt in my study period, like even though platelets are less than uh, like 1 lakh, or if the value is 90,000, they'll get scared. Oh, platelet has come. Oh, platelets, if it is less than 70,000, there is risk of hemorrhage. You should be cautious, but you should feel when to act. Okay, then chorioamnitis infections. If BMI is more than 50 also, it's a risk for hemorrhage. We should be ready for everything. Blood bank should be available, response checklist, and reporting if there is any hurdles. Management is first you do blood grouping and screening, CBC, coagulation screening, including fibrinogen. You'll do vitals for every 15 minutes. You'll start the crystalloid infusion. Warm, remember this warm. And we should decide when to do blood transfusion. Okay, and optimal survival should be done. And before giving blood transfusion, informed consent from the patient should be taken if she's conscious. Blood components are like some technical aspects are there. Like see, when the person came in shock, you'll start the IV fluids if the blood came now. Can we connect in the same IV line? No, we should not give in the same IV line. It's not advisable. If a blood came, it is transfused. Another blood came. Now we are giving the second unit blood. Can we transfuse with the same IV line? Yes. Same BT set can be used up to 12 hours. Okay. Only for blood. If it is PRPC, then PRPC only should be used. If the next component is FFP, you can't give with this IV line. You should change the IV line. Okay. For fast IV transfusion of blood, some use external pressure devices, but the pressure should not exceed 300 mm. Okay. And other medications or anything should not be given in the same IV line. Okay, we should observe the vitals also. And what is massive transfusion? We know in one day, if 10 units of blood has been given, that is massive transfusion, or 1 hour, if 4 units of blood is given, that is also massive transfusion. So if the question comes massive transfusion, then you should write these four definitions. Okay, in one day, if it is more than 10 units, if 1 hour, if it is more than 4 units, or rate of blood loss is more than 150 ml per hour, you are giving. If there is loss, that is, we are giving. That is massive transfusion. And almost we are replacing the 50% of blood volume in 3 to 4